Hey guys, today we are going to talk about migraines, ways to detect them, some red flag signs, some simple treatment strategies, and then differentials from other primary headaches. So typically migraines, they are pounding headaches, and so you can remember the mnemonic pound 5 by a pounding headache. P is pounding or pulsatile. The onset or duration is typically 4 to 72 hours, so it can last anywhere from a couple hours to a couple days. It usually presents unilaterally, not always, but that's the classic presentation. And then usually you have nausea with or without photo and phonophobia, so sensitivity to light and sound. And then usually it's disabling. That's one of the hallmarks also of migraines, is that you can't go about your normal activities because the migraine is just so severe that it interferes with your daily activities. And then for the 5, so if you have 5 or more occurrences throughout your whole life, that counts as having migraine disorder. And so once you hit 5, you officially have the migraine diagnosis for the rest of your life, even if you don't have any more. Some red flag symptoms to be cautious of with migraines are something that comes on super sudden and super severe. So you may have heard of the thunderclap headache for subarachnoid hemorrhage. Of course, if anyone has symptoms like that, that is concerning and they should get further workup. Typically a migraine comes on a little bit more progressively with or without an aura, but it's a little more slow of an onset. Other thing is if someone has a different quality than usual, if they come to you and say, this one just feels a little bit different, I don't have it like this usually. Typically migraines present in people fairly similarly from episode to episode. And so if they're having different symptoms or it feels different, definitely take that seriously and don't just chalk it up to another migraine. If they're having any sort of neuro changes, so if they're having syncope, seizures, neuro changes like altered mental status or anything like that, then that definitely warrants further workup. Some patients will get neuro changes with their aura, so they'll get a little bit of confusion, they'll get a little bit of even motor symptoms, almost similar to a stroke. But if this is new for the patient and that's never happened before, like I said, usually the aura is pretty, it's the same every time. And so if they've never had that, that's definitely warrants further workup. And then if they have a fever, you want to be thinking about meningitis, or if they have their first occurrence over the age of like 30, then you would also want to be concerned and probably get a little bit further imaging just to rule out any sort of mass. Typically migraines start in childhood or adolescence, and so even migraines starting for the first time in your 20s or 30s is fairly unusual for migraines. So that first one you definitely would want to work up to make sure you're not missing anything else. So moving on to treatment, the most widely accepted mechanism for production of migraines is that there's an increase in CGRP in your brain, and that causes vasodilation, which then results in the headache symptoms. So I was taught to think of this chain of reactions as kind of like a conveyor belt system. So the CGRP would be the machine that's producing the products, and the products, which is the CGRP, makes vasodilation occur, and you can think of that as like the conveyor belt that's bringing the products to the rest of the brain. The headache symptoms would be whatever that product is that you're making. And so the reason why this analogy I think is really helpful is because if you just turn off the machine, but the machine has already made a bunch of products like the CGRP and the conveyor belt is still on, you're still going to get headache symptoms because you're still going to get vasodilation from the products laying around. Therefore, you're still going to get headache symptoms. Or in the same way that if you turn off the conveyor belt, so say you turn off vasodilation, but you still have all of those individual products laying around, you're still going to have headache symptoms because you've stopped creating any more products and shipping them around the brain, but all the ones that are there continue to be there. So usually it's a combination method that works the best with migraine. So we'll start with vasodilation because that's the most common medication used. So triptans fall in this category. They vasoconstrict. And then caffeine also falls in this category, and that vasoconstricts in your brain. Headache symptoms, that's usually just kind of what we talked about over in the pound 5. So that is pain, nausea, all that sort of stuff. So you can give some antiemetics that are usually helpful for that nausea. And then also just like Tylenol and NSAIDs and more of like symptom management over on this side. And then CGRP antagonists. So those are kind of where migraine medicine is producing the most right now. So there's a bunch of new medications on market like Emgality and Nurtec and Ubrevely and all of these stuff that is not covered by insurance. So typically your treatment is going to be between these two categories just because CGRP antagonists are still kind of being developed. But I'll write a couple up here. So we have Emgality, Nurtec, and then Ubrevely. So those ones address the CGRP specifically, but even if you're using those, it's the same analogy. So you would still want to address the CGRP plus vasodilation and or the headache. And so for abortive medication, the earlier you can get those medications on board, the better. Kind of going back to our machine analogy, the less of products that are out and about in the brain, the less medication it will take to kind of help with those symptoms. And so the sooner the better for abortive medications. And so you usually want a combination. So you want a vasoconstrictor plus symptom management, which would be these guys. So you typically would want like a triptan, Tylenol plus Zofran or something for an antiemetic, or Excedrin is a really popular medication for headaches, and that is caffeine and Tylenol. So we can see how it kind of it encapsulates both the vasoconstriction and the headache symptoms. That's how you'll get the best relief for abortive medications. When you're looking at preventative medications, you want to start doing these when migraines get more and more frequent. You should not use triptans more than 10 days a month because then you can get rebound headaches. And so if you're getting close to using your triptans that much or using your other medications for abortive medications over 10 days a month, then you may want to talk about doing preventative with your patients. And so the first line for preventative is actually topiramate. So that is initially made as a seizure medication, but it is now recommended as first line for prevention of migraines. Doesn't help with abortive, but does help to prevent it from starting in the first place. Also, you can try TCAs, SNRIs, beta blockers, and then also magnesium has been shown to help. Careful with magnesium because it can definitely cause your patients to have GI upset as well. But those medications, starting with topiramate, are the ones that are most accepted for starting preventative for your patients. And then also lifestyle things like making sure they're drinking enough water and they're exercising and they're not having too much caffeine. All of those have shown to help with prevention of migraine onset as well. So just two other headache differentials that I'll talk about real quick. First one being cluster headache. So this is a headache that sometimes can start like a migraine. So it's a fairly severe headache, and then it's typically seen in middle-aged men. This one comes on a little bit more suddenly, and then for some reason, so we're gonna put men here, we're gonna put sudden, And then a lot of times it will happen multiple days in a row, and then it'll last for a couple hours instead of a couple days. So I'm just gonna put recur. So they recur a lot, usually in a short period of time. So within a week, you would get lots of headaches about at the same time every week. So that would be more of a cluster headache sort of picture. Treatment for this would be actually oxygen therapy has shown to be helpful. Otherwise, just symptomatic relief mostly. The abortive medications will not typically work on cluster headaches just because it's a different mechanism of action. And then the other kind of headaches that you'll see a lot will just be tension headaches. So these typically come from, it can come from like tight musculature in your neck, or it can come from stress, or usually it presents as a frontal and occipital kind of band-like headache that goes around the head. Sometimes people will say that it starts at the back of their neck and then kind of goes towards the front of their head. And so I'm going to put band-like on here. That's kind of a buzzword for boards. And then similarly to cluster headaches, there's not a lot of specific treatments for these other than the just symptomatic relief. So you could just do some Tylenol. If you get nauseous, you could do antiemetic, stuff like that. So this was just a really quick rundown of migraines. Remember the pound 5 mnemonic. Definitely remember the red flag signs, because those may come up on your test, and that will definitely change your answer. And then just remember kind of the machine thought of treatment management, and that you typically need to cover at least 2 of these of the spots, so like vasoconstriction and the symptoms, or like CGRP antagonists and symptoms, in order to effectively abort the migraine. Sooner the better. There are preventative medications out there, starting with topiramate, and then just remember the differences between these migraine symptoms and then cluster headache or tension headache, because that will definitely be a question on your exam. Good luck.